Good afternoon and welcome to today's webinar, Empowering Nurses for Early Sepsis Recognition, hosted by the Centers for Disease Control and Prevention in collaboration with the Society for Critical Care Medicine and American Nurses Association. My name is Abigail Tumpy. I'm Associate Director for Communication Science at the Centers for Disease Control and Prevention's Division of Healthcare Quality Promotion. This webinar is part of a series of webinars that CDC will be hosting with a variety of external partners and experts. Today's webinar features an expert panel, including Dr. Ernest Grant, President of the American Nurses Association, Dr. Anthony Fiore, Chief of the Epidemiology Research and Innovations Branch at CDC's Division of Healthcare Quality Promotion, who will provide an overview of CDC's recently released Vital Signs Report on sepsis. Dr. Sean Townsend, Vice President of Quality and Safety at California Pacific Medical Center, who will discuss expanding sepsis early recognition and lessons learned from engagement of nurses. Mary Ann Barnes-Daly, Clinical Improvement Performance Specialist at Sutter Health System, who will discuss a pilot of sepsis early recognition in Sutter Health. Also joining us is Christa Shore, Associate Professor of Medicine at Cooper University Hospital, who will discuss lessons learned from implementing sepsis screening on hospital wards. Before we get started, there are a few housekeeping items to cover. First of all, we welcome your questions. Please submit any questions or comments you have via the chat window located at the lower left-hand side of your webinar screen. You may submit questions at any time during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located at the top left-hand side of your screen if you need to chat with a meeting chairperson for assistance on technical difficulties during the webinar. As a reminder, the audio for today's webinar should be coming through your computer speakers. Please ensure that your speakers are turned on with the volume up. Now it's my pleasure to introduce Dr. Ernest Grant, President of the American Nurses Association. Dr. Grant?
Thank you, Abigail, for that kind introduction. Although I must make a correction, I'm the Vice President of the ANA, not President. But it is my pleasure to say a few words about the American Nurses Association and the nurse's role in sepsis recognition during Sepsis Awareness Month. First, a few words about ANA. ANA has a long history of supporting the nation's registered nurses. This year, we're celebrating our 120th anniversary. As the premier organization for all RNs, we represent the interest of the nation's 3.6 million registered nurses. ANA is at the forefront of improving the quality of care for all. Infection prevention is a major priority for ANA and the nation's nurses. ANA knows that nurses play a pivotal role in recognizing and preventing sepsis for a number of reasons. As the most trusted profession 14 years in a row now, nurses share in patients' most vulnerable moments. There is also strength in numbers. 3.6 million RNs means that there are more than 7 million eyes on patients, monitoring their vitals and looking for the key signs of sepsis, including fever, disorientation, or shortness of breath. Finally, nurses spend the most time with patients. It's likely that a nurse will be able to recognize subtle changes in health status and behavior that could indicate the onset of sepsis. One common way for patients to develop sepsis is through urinary tract infections, or UTIs. In fact, UTIs are the most common reported hospital-acquired condition, and 75% of UTIs are catheter-associated UTIs. RNs can play a major role in reducing CAUTI rates to save lives and prevent harm, including the development of sepsis. This is why ANA developed this evidence-based clinical tool in conjunction with leading experts, including many from the CDC. The tool is an easy-to-use checklist and decision algorithm and free to download. please see the ANA CAUTI website for more information. This tool is just one way ANA is working to help nurses prevent infection and can lead to sepsis. In closing, ANA is proud to partner with the Centers for Disease Control and Prevention on this webinar and in a number of other ways. Over the next 2 years, ANA and the CDC will be working together to enhance education and training on infection control for U.S. nurses. ANA will leverage its relationship with more than 20 specialty nursing organization partners to develop training to improve nurses' adherence to and confidence in performing infection control procedures that could protect both themselves and their patients. ANA and the CDC have also partnered to identify nurses' roles in antibiotic stewardship. Through this work, we will codify how nurses contribute to antibiotic stewardship programs. As we know, antibiotic misuse contributes to the emergence and spread of antibiotic-resistant superbugs that can lead to sepsis. Finally, as part of our ongoing partnership with the Association of Professionals in Infection Control and Epidemiology, ANA has launched our Infection Prevention and Control website, shown on the slide. I encourage you to take a look at the evidence-based prevention and control practices on the site. As you will hear throughout the hour, nurses are vital to preventing sepsis and other infections. I will look forward to hearing from our esteemed panelists. Now I'd like to turn this over to Dr. Fiore with the CDC.
Thank you, Dr. Grant. I'm really happy to be here and look forward to hearing more from the other speakers about the important role that nursing staff can play. So I'll be very brief in describing what came out in the CDC Vital Signs report on August 23rd and that we continue to promote over the course of Sepsis Awareness Month. First, we found that sepsis begins outside of the hospital for nearly 80% of patients. Another important finding was finding that 7 in 10 patients with sepsis had recently interacted with healthcare providers or had chronic diseases that required them to get frequent medical care. And what this tells us is that there are opportunities to better prevent infections and recognize sepsis early to save lives. There's a chance here for providers to talk to their patients about infections and sepsis, about how infections that can lead to sepsis can be prevented or recognized early, and what they can do if an infection is not getting better and looks like it could be at risk for sepsis. Now, nursing staff, of course, plays a role both in inpatient and outpatient settings, and you'll hear a lot about the inpatient setting. And I'm talking now a little bit about what goes on with what happens before people get to the hospital. But it's also important to know about the risk factors for sepsis, and this applies both to people in and out of the hospital. Sepsis most often occurs in the people that are most vulnerable, and those are over the age of 65, infants that are less than 1 year of age, those with chronic diseases, particularly diabetes or weakened immune systems. It also most commonly occurs after an infection in the sites of the lung, the urinary tract, the skin, or the gut. There are certain very common bacteria that cause sepsis, and they're going to come as no surprise to you that this is the most common are Staphylococcus aureus, E. coli, and some types of streptococcus. However, for many patients, no causative bacteria is ever actually isolated. But it's important to remember, despite me telling you about the risk factors, that even healthy people can develop sepsis from an infection, and it's especially true if the infection is not treated properly and early. So what can healthcare providers do? Well, you're going to hear a whole wealth of practical information in just a few minutes, but the overarching message is that healthcare providers really are the key to preventing the illnesses that can lead to sepsis. They should educate their patients and their families about the early signs and symptoms, what to do if they feel like something that an infection is not getting better, and this is especially important for those at higher risk of getting sepsis. Remind patients that taking care of chronic illnesses is one way to prevent infections that can lead to sepsis, and encourage typical infection control measures, including things like hand hygiene and also vaccination against infections that can cause sepsis. And what you'll hear particularly more about today is sepsis recognition and treatment. So it's important that healthcare providers think sepsis by knowing about sepsis signs and symptoms, act fast if it's suspected, and then once the intervention bubbles have begun, reassess patient management and tailor it to the conditions of the patient, including changing antibiotic therapy as cultures and other laboratory tests dictate. And so with that very brief overview of the Vital Signs report, I'm going to turn it over to Dr. Sean Townsend.
Thank you, Dr. Shore. I appreciate that very much. Very important information, a very interesting vital signs report. As part of our work today, I'd like to introduce the topic regarding how the Surviving Sepsis campaign worked to improve sepsis recognition on the wards and how we worked with nurses across the country to make this possible. I have several objectives that we'd like to accomplish. I want to talk, of course, about sepsis on the wards and what we did to get there, and my colleagues will speak mainly about this. We'll talk a bit about the pilot program we did and how we got this started across the country. And then we're going to talk about lessons learned along the way. And integral to all of this, of course, was the key assistance of nurses to make the work possible. I'd like to start, though, first by telling a story about a patient who developed sepsis. This is Rory Stanton. Rory Stanton was 12 years old, living in New York City, when he was playing sports outside of school with his friends, and he slipped and fell on the basketball court and scraped his arm. Rory then got that wound dressed, went home, and was brought home by his parents and started to feel ill. He developed fever that day and then became nauseous and vomited several times. This didn't stop, and he became progressively more ill. His parents got rather concerned. They contacted a pediatrician, and the pediatrician felt that he probably had gastroenteritis and thought he was dehydrated. He recommended that Rory be brought to an emergency department for rehydration, and in fact his parents did that. They brought him to the hospital. When Rory was seen in the hospital, he got some IV hydration. They took his labs, and they also checked his vital signs. But after the hydration finished, he was discharged from the emergency department before his labs were actually finally checked. The final results were in, and when his last set of vital signs were taken. Had he not been discharged so quickly after receiving his fluids, they would have noticed that Rory had a very high white blood cell count and that he had tachycardia in excess of what you'd expect for his age. He did go home, however, and he got worse that evening. He became progressively ill, more nausea, more vomiting, very high fevers, couldn't sleep that night, and neither could his parents. By the time he got so ill that he was not responding to his parents appropriately, they brought him back to the emergency department. And unfortunately, for Rory's case, when he arrived, he was unable to tolerate the burden of his illness anymore and suffered cardiac arrest and died. And this story is integral because it's really changed the face of the way we look at sepsis in the last 4 to 5 years. Rory's tragedy, of course, wasn't taken lightly by his parents. They took this matter into their own hands because of the fact that he would have been left the emergency department without having a complete check of his vitals and complete check of his labs. And they recognize something that we've all come to know now, which is that sepsis is hard to identify, and that even when at the hospital and in the presence of providers, you can oftentimes miss the disease. Rory's parents are shown here in this slide, and you can see that they got to they made it to the Today Show to tell their story, and they not only were on the Today Show, they continued to advance this story and didn't let go of it. They, in fact, have now started a foundation to advance the care of patients that have sepsis, severe sepsis, and shock. And they've tried very hard to make an impression upon our leaders. They did, in fact, approach the Department of Public Health in New York State, and they worked very closely with that department to begin the process of finding ways for hospitals to improve the care for sepsis patients. They didn't stop there, though. They went to the U.S. Congress, the Department of Health and Human Services. They testified before the Senate House and Human Services Subcommittee. And they also lobbied the Centers for Medicare and Medicaid very effectively about the need to establish measurement on the way we care for patients with sepsis. You can see that they ultimately achieved success in New York first. Governor Cuomo signed into effect rules that required every hospital in the state of New York to report on the processes of care that they were going to use to identify sepsis patients and then to care for those patients after that time. This landscape clearly was changed by Rory's story, and governments began to respond to the nature of the disease. In the United Kingdom, all of Great Britain developed sepsis measures very similar to the ones that were put in place in New York State. And in the United States, there were some reasons why the Centers for Medicare and Medicaid began to take greater notice, too, of this disease. not only were Rorys Parents lobbying CMS to get the work done that was necessary to improve care for sepsis, but there were some demographic reasons why also Medicare and Medicaid began to look at this more closely. So here you're seeing data from the Center for Health Statistics, a part of HHS. And what you'll see is in the blue, you've got men are in blue, and women are listed by the green chart, the green bars. Across the bottom on the x-axis, you have age. And on the y-axis, on the far left, you have the rate of the disease per 10,000 of population. And what's pretty clear, I think, from this graph is that the disease takes its effect and begins to pick up at age 65 to 74. At 75 to 84, it's even more prevalent in the population. And finally, 85 and over is the highest incidence of the disease. Of course, this is very important to Medicare. Unlike Rory's story, Rory, of course, being only 12, was somewhere down here in this fraction of folks who developed the disease. But what you see is this payer group here is what Medicare's population was. And so hence, there was a great emphasis to establish a sepsis measure across the country. The next slide shows you the final reason why I think Medicare took an interest in this, and this has got a lot to do with the work of nurses and doctors at the bedside. You can see between the years 2000 and 2008 on the x-axis on the bottom, the rate per 10,000 of population for diagnosis of sepsis. Green represents here sepsis as a primary diagnosis, and blue represents sepsis as a primary or a secondary diagnosis. And just looking at the green line, you can see back in 2000, the rate per 10,000 of population was 11.6. That rate nearly doubled by 2008 to 24.0. And the reason for this are two things. The population was aging, for one thing, and we just saw in the previous slide that as the population ages, we're likely to detect the disease more frequently since it's a disease mainly of the elderly. But also the work that was happening with the Surviving Sepsis campaign, encouraging screening, and the screening that was going on by bedside nurses began to pick up increasingly across the country. With increased screening and detection, of course, the incidence would rise as well. And these things together have brought a new era of sepsis measurement to our hospitals under the form of SEP1, the national measure for sepsis. A key to detecting that, however, there was going to be the work that nurses do to do the screening for sepsis. Finally, one key point to make here about demographics is just this. Sepsis remains the #1 cause of inpatient deaths across the country. This is data from my own institution, Sutter Health in Northern California. And in 2014, if you look at all the discharges in our hospital on the far left, you see that there were only 11% of them had sepsis as a diagnosis at discharge. But if we looked at the deaths that occurred in my health system in 2014, 48% of the patients someplace had a diagnosis of sepsis in their chart. And so this remains true not only at my institution, Sutter Health, but it's a national trend. And we know that the majority of deaths that occur in hospitals share a diagnosis of some type of sepsis at the point of discharge. So people do die from this disease, and where do they die is an important consideration. And I'd like to just point out to you that the work on medical surgical floors is really critically important to finding patients with this disease. The ED is where we typically think people present to, much like Rory's case. He came into the emergency department. But there are a large number of patients who are already in the hospital who develop sepsis, and the work on the medical surgical floors is very important to detect sepsis there. In this publication, you can see that the source is listed on the far left of where the patients presented from, and the mortality is listed on the far right. And please note here that the patients who were on the wards where their sepsis was identified had the highest mortality compared to the emergency department and the ICU at 46.8%. That's higher than the ICU patients who had developed sepsis at 41% and the ED at 27.6%. So clearly, the high mortality in the wards justifies a good screening effort that we hope to do on medical surgical floors. And that can all be said one other way. If we risk adjust all that data and say, well, let's look at these patients to see what their comorbidities were, does that still stand out that patients who present from the wards are more likely to die than patients who come from the emergency department? Well, the answer is yes. The same publication showed that the odds ratio of death for patients who present on the medical surgical floors is 1.87, and clearly that's an unacceptable risk overall. This makes the work that we're going to describe to you really important on the medical surgical floors, and it's my pleasure now to introduce Marianne Barnes-Daly, who's going to tell you quite a bit more about that initiative.
Thank you, Dr. Townsend. Good afternoon or good morning, everyone. I would like to take this opportunity to share with you some work that was done at Sutter Health in 2010, about the same time that the article was published that Dr. Townsend just shared. It was clearly understood that although much work was happening in the emergency departments where patients typically present, and also in the ICU where we treated our most ill patients, typically with septic shock, that there was a missed population. That is, patients who were right under our noses who were either had worsening sepsis or were developing severe sepsis or shock while patients in our hospital. I'm going to briefly describe to you a program that was undertaken at Sutter Health in Northern California. This project was supported in part by a grant from the Gordon and Betty Moore Foundation. And the foundation tasked us with continuing to make improvements in both the ED and ICU venues, but to add a new focus to our work, and that is early identification and early implementation of treatment for patients in the med-surg areas to prevent those patients from worsening and dying. In the particular hospital where we piloted, we made up a great little acronym, the Medical, Oncology, Surgical, and Telemetry patients, or MOST, and they were in fact most of the patients who were in our hospital. Our outcomes were for those patients who were eventually transferred to the intensive care unit. We looked at mortality and bundle compliance data for these patients. They were analyzed by their location at time of sepsis presentation, and we used these data for continuous quality improvement. I'd like to share with you our baseline and then outcome findings. So you'll see here in the blue bars our data for mortality rates for the calendar year of 2010. You can see that our overall combined mortality rate for patients who went to the ICU, both coming from the emergency department directly or from an inpatient med-surg unit, combined we had a mortality rate overall of severe sepsis of 22.8%. What you'll also notice here is exactly what Dr. Townsend shared with the Surviving Sepsis Campaign data, is that patients going directly from the emergency department to the ICU, although presumably sicker, actually had a lower mortality rate than patients who were identified on the inpatient or most units who eventually were transferred to the ICU. So we set about to create a model or a protocol around which we would have better opportunities to recognize and intervene earlier in this patient population. So we created a protocol by which the med-surg nurses would screen patients once per shift. They would call a sepsis alert, at which point the rapid response team and a physician would respond, and they would begin the severe sepsis bundle and evaluate the patients for the presence of septic shock. After implementing and piloting that for a year, we then felt we had sustainment the following year in 2011, and we collected and reported data at that time. You can see then the 2011 data represented in the red bars, and we see two things that are very notable. The first is that our overall combined mortality rate was about dropped in half based on the work. The second thing that we can see is that the mortality rate for patients originating in the emergency department was almost identical to the mortality rate for those patients who were identified on the most units. We felt that that showed that we had correctly identified and intervened on that patient population, and we felt at that point that our program was a success. We spread it then to the other 7 hospitals in that region of our medical system, and ultimately to our entire 25 acute care hospitals. I would like at this time to turn the presentation over to Christa Shore.
Thanks, Marianne. So I'm actually just going to give an overview of the Surviving Sepsis Campaign Phase 4 Sepsis on the Wards Collaborative. And this is actually springboarded from some of the work that actually Marianne has presented, in addition to our continuation of the Surviving Sepsis Campaign work in Phase 3, the data that actually Dr. Townsend had shared. This is the timeline for the Phase 4 Collaborative. We had 60 volunteer participating sites within 4 regions of the United States, the East Coast, West Coast, Midwest, and southern states, primarily within Florida, the Adventist Health System.
We kicked off the project in January of 2014. We had 3 in-person learning sessions within the 4 regions. Each had 3 sessions. We also included either a monthly webinar or a conference call, coaching calls to help the sites move the project forward. Each particular region actually had a specific faculty that included a member of the Surviving Sepsis Campaign leadership, a nurse leader, a performance improvement leader, as well as a hospitalist. And we thought that that was really important. We did partner with the Society of Hospital Medicine, recognizing that our hospitalist partners were going to be key in moving this program forward. And again, the project was funded in part by the Gordon and Betty Moore Foundation.
Krista, if I can just pause you for a second, if you could get closer to your phone, some of our participants are having trouble hearing you.
Okay, is that better?
Yep, even a little louder would be great.
Okay. So our primary focus was on early identification. So again, similar to what Mary Ann had mentioned, our goals really were to identify patients early, whether it was a confirmed diagnosis or a suspected diagnosis. Our goal was really to identify patients early so that we can implement the bundle. So our focus on the wards was really the 3-hour bundle, which includes lactate, blood cultures, early antibiotics, and if necessary, implementation of early fluid resuscitation. And again, we felt that these interventions could be implemented on the general medical floor, and if we were able to identify patients early and implement these 3-hour bundle elements, that potentially the patient could remain on that general medical floor, or if they did require an ICU stay, that our thought was that their outcomes would be improved or their stay in the ICU would be shortened. The tool that we provided at our first learning session, again, was the Evaluation for Severe Sepsis Screening tool, which we had used in the emergency department and the ICU in collaboratives in previous work. And our goal really was to use a tool that we have shown that was successful, and this is actually very useful on a general medical floor in identifying patients with infection, signs and symptoms of infection, and organ dysfunction. And what is unique about this particular tool is that the thought process behind the tool is that we could help the nurses understand all the potential signs and symptoms to be observant of, and to assess patients for the development of organ dysfunction in those patients potentially that are being treated for an infection. So for instance, if we have a patient who is admitted to a general medical floor with pneumonia, and they're actively being treated with antibiotics, and on day 2 or day 3 the patient is not improving or actually worsening, developing a new organ dysfunction, our thought behind this was that the nurses will be able to recognize that and intervene sooner, because the patient's actually having a progression of the disease, and the nurse can potentially intervene at that particular point. So again, this particular screening tool we felt was really important, and a paper form that the nurses understand the process and how to think critically through each stage to identify a patient that is developing severe sepsis or who is presenting. Even, unfortunately, we do have patients that develop nosocomial infections and can progress through this process very quickly. So again, we felt that this tool was essential to share with the collaborative sites. We opted to let the sites determine how they were going to incorporate this tool into their screening process. So some sites opted to use the paper screening tool, and others actually incorporated into their electronic health record as an alert. Again, this actually took some time, so some sites right away we got started with the paper tool, and other sites slowly incorporated this into their electronic medical record, which took several months. So there are varying degrees as to how long this actually took in these particular sites. One particular point I wanted to make was we recommended that the sites only pilot this on one particular unit, because we recognized that this was a lot of work, and understanding how this particular screening process would unfold in a hospital setting, we really were unsure. But based on the work that Mary Ann did, the recommendation was that we pilot this on a unit, and then when we learn from that success, then we can trickle on to other units. So we actually recommended this as well. The mantra that we acquired during this process was screen every patient, every shift, every day. And one point that Mary and I feel very strongly about is that it is important that we have the nurses understand the screening tool prior to implementing the electronic alert, because they need to understand the background for why an alert is potentially firing. And I learned this the hard way when I was in a recent meeting with new nurses in my facility, and I mentioned that I was involved with sepsis performance improvement, and I heard a lot of sighs. And the challenge behind that is that there is an electronic alert, but the new nurses really don't understand the background as to why that alert is in place. And I think it's important that we understand that there are folks that are actually coming to our facility at different time points, and that we need to educate the nursing staff as to why some of these alerts are in place. And they also need to understand the steps, the critical steps in identifying a patient that potentially is actually on a downward spiral from an infection that is actually being treated. So the pilot unit, so we actually had the units participate in a survey. So those 60 sites that participated in this nationwide collaborative, the units that participated were primarily medical surgical units at 50%, straight medical units 34%, and then we had the other, which is about 16%. And some of these units were very similar to what Mary Ann described as the most units, the oncology unit. We did have one or two labor and delivery or high-risk maternity units that were incorporated here. But again, the nurse-patient ratio on these particular units ranged between 1 and 5, and there was one particular pilot unit that actually had a 1 to 9 ratio, which we found somewhat challenging. But the important thing about sharing this data is that the pilot units that participated in this program had a variety of patient populations as well as nurse-patient ratios, and they were not only academic centers, but they were also community facilities as well. So we had a variety of participants in this collaborative. So the inspiration, I think, should be there for other sites to incorporate this program into their facility. At the end of the program, we submitted another survey and looked at the screening compliance on these particular units, and 75% of the sites actually achieved greater than or equal to 80% screening compliance in every patient, every day, and every shift. So when we think about the work that is actually required from the nurses in screening a patient, this is very doable, and we did show success. It was a time sequence. It did take a bit of time, but this is very possible. So if you're going to present this to the leadership in your facility or the nurses on your particular unit, I think we need to ensure that we can share that despite this being a challenge and maybe difficult up front, it is a possibility, and we can do this together. So how do we actually go about doing this? And Mary Ann and I both feel very strongly that nurses are in a great position to help this program move forward. And I think the physicians in our group, the faculty leadership in the collaborative felt very strongly that there was no way that this WARDS program would get off the ground without the assistance of the nursing staff. So we feel very strongly and very similar to what Dr. Grant had mentioned, that the nurses are the eyes on the patient. So these are the key staff members that are really going to help us move this program forward. So I think what I'm going to do is over the next several slides show some methods on how we can inspire nurses to do the routine screening that would include leadership and staff, how and why we're doing sepsis screening, and how to implement the program. And I just wanted to make a point here that if you're going to introduce this program, I learned this again the hard way, that we don't want nurse buy-in on this program, we want nurse engagement. Because if we think about buy-in, it's basically someone else coming up with an idea and asking the nurses to accept that idea and move forward. If we have nurse engagement, they're actually absorbing this particular disease process. They understand the pathophysiology behind it. They understand the why. They understand the data, which Dr. Townsend had shown, and they understand the impact this is having on their facility as well as their patients on that unit. So nurse engagement is going to be key. Nurses, again, are in the best position, we felt, to make a difference. They're the main caregivers in the hospital setting. Again, all the eyes are on the patient. They are able to recognize the changes in the patient condition. Sometimes we, as nurses, see changes in the patient's condition, but we're not sure what to do with that information. How do we report it? How is it received by our clinical partners? Again, we need to partner with our hospitalists and internal medicine and our providers. If we have nurse practitioners and physician's assistants, again, partnering with our providers is key into moving this process forward. And again, the nurses are there coordinating care, so we need to offer assistance and support along the way to make this program successful. So the purpose of nurse screening for sepsis, again, we share all this information with the nurses. We're not just going to ask the nurses to start using a screening tool. We need to have the nurses educated as to why we're doing this. What's the purpose of the screening? Show me a patient on our unit who unfortunately had a sepsis episode and maybe had to get transferred to the ICU or had a poor outcome, or a patient where we actually had a good outcome. Show me a patient where we did everything right, where we were able to recognize the signs and symptoms early, were we able to intervene early. Again, I mentioned about the organ dysfunction. I think progression of organ dysfunction is sometimes what really is the detriment to these patients. So if we're able to identify the patients early and prevent progression of organ dysfunction, that's key. And it's very difficult to measure prevention, but I think in the overall scheme of the hospital, you'll recognize that the mortality for this disease will go down. And then the other important factor is evaluating patients. So if we're treating a patient for an infection, such as pneumonia, is the patient getting better? Are we evaluating their condition to see are we treating the patient with the appropriate antibiotic? So again, I think the nurses are in a perfect position to make a difference with early intervention, prevention, as well as evaluation. Understanding why, I did mention that. It is important for the nurses to understand why we're using that particular screening tool, why we're asking them to screen for severe sepsis or sepsis in our facility. You know, they need to understand there's a pathophysiology that's occurring behind the scenes. We're not just asking them to look for patients with a fever and a high white count. There are other signs and symptoms that are in the mix. How does infection and resuscitation go hand in hand? So again, the understanding of how all these things come together to display a patient with severe sepsis is really important. And I think we need to give our tools to the nurses so that they're knowledgeable. So when they're delivering this information to the healthcare providers, that they feel confident in this particular diagnosis. And I feel personally that the nurses have the capability of doing this. We just need to give them permission and the tools to move this program forward. So I'm going to pass the presentation on to Mary Ann, and she's going to continue on with the education process.
Thank you, Krista. To further add to what Krista mentioned, when we empower the nurses with the understanding of the pathophysiology of sepsis, particularly things such as vasodilation, capillary leaking, a decreased cardiac function, when nurses understand that's why they're screening for the items in the sepsis screen, and that they can literally save a life with some normal saline and an early hung antibiotic, they become zealots for using the sepsis screen and early identification. But in addition to the understanding of the pathophysiology of sepsis, as previously mentioned, RNs really need to be trained to effectively communicate the results of the sepsis screen, and most importantly, they need to be supported and empowered to make a recommendation for the next steps for patient care. In order to do that, RNs need to know and understand the elements of the sepsis bundles in order to make those recommendations, and also to prioritize interventions and to optimize resources. For example, if a patient is going to require both a 2-liter saline bolus and a broad-spectrum antibiotic, it would be important for the nurse then to prioritize starting the bolus first, and also to give the antibiotic while the bolus is running so that everything can be given to the patient as early as possible. SBAR is a tool that's used successfully for communication. It's widely used and has demonstrated success when nurses are sharing information with providers and physician colleagues. The nurses need to understand the components of the bundles. Here is a pretty handy badge card that's available on the Surviving Sepsis Campaign, Society of Critical Care Medicine's website, which allows nurses, when communicating with providers, to not have to remember what the steps of the bundle are, but to have them available for reference as they're speaking to their physician colleagues. Important is for the nurses to understand where screening plays a role in their assessments of their patients, both when they start their shift and on an ongoing basis. So Krista shared the mantra, screen every patient, every shift, every day. So that starts off with screening a patient at the start of every shift. Implicit in that is also screening a patient that's received in transfer from another unit, or of course, a new admission. It's also important to critically think, as Krista mentioned, that if a patient does have a change in condition, and the fact that sepsis is one of the most common occurrences in our hospitals, that when change of condition does happen, we invite and encourage our nurses to use a sepsis screen to either rule in or rule out sepsis as a possibility. There should also be things in place to help the nurse properly respond or to share information when a screen is positive. And often that is in the form of a consult with the rapid response team, where a nurse with a higher level of training or more experience would come to verify the fact that the sepsis screen is positive and to help implement a proper response. Consider using standard work as a way to empower the nurses to respond and share information around a positive sepsis screen. This might be a policy or an algorithm for nurses to follow in response to a positive screen. It would allow the nurse to coordinate with providers and the rapid response team as a second tier. Also consider in that standard work a nursing standardized procedure, which will allow specially trained nurses, like the rapid response nurse, for instance, to initiate labs and perhaps a fluid bolus for hypotension during the time in which the physician is being contacted. It's also helpful, as I mentioned earlier, for the rapid response nurse when he or she comes to the bedside to either verify or not the sepsis screen, in addition to providing encouragement and feedback to the bedside nurse. It's a very important teaching moment. The rapid response nurse can initiate the standardized procedure and also help with facilitation of communication with the provider. This is an example of effective communication using the SBAR format. In this case, the nurse contacts the provider and says the situation first. Mr. Smith was admitted early this morning with cellulitis of his left lower extremity. He states the pain in his leg has increased and the redness has extended. Another option for providing information starting in SBAR using situation is simply saying, Mr. Smith in room 307 now has a new positive sepsis screen. The background then would be briefly about Mr. Smith, his age, his history of comorbidities, and the fact that his wound on his left lower leg has been present for about 2 weeks and he was admitted through the emergency department. The assessment then that the RN provides is the vital signs this morning and any changes or concerns with those vital signs as reported to the physician in addition to laboratory results that are germane. And most importantly then is the recommendation. In this case, the nurse says, I would like to request an order for a chemistry panel, a CBC with differential, and a lactate level. Based on the patient's vital signs, the nurse may also ask for a fluid bolus order and review of current antibiotics to be sure that we are adequately covering any suspected organisms, or perhaps ask for an order to give a broad spectrum antibiotic if the organisms have not been yet identified. It is so important to empower the nurses to be able to feel comfortable providing this information to physicians on the phone, and the presence of the rapid response nurse or having that nurse actually provide the communication to the physician can model and mentor this behavior to the bedside nurse who may feel less confident and encourage that nurse to use the same type of communication strategy and to improve confidence with the next time a call needs to occur. If you haven't yet started a program such as this on your inpatient units, there are considerations for piloting the program, as Krista elucidated earlier. It's really important to choose a single unit to start first. As in the IHI model for improvement, doing small tests of change are really important, both to not overwhelm people, but to also implement a project and then learn from several iterations over time. When you're considering a unit in which to pilot, these considerations we feel are important. Choose a unit with a positive environment. We all know that med-surg nurses are among the busiest in our hospitals, and it's important to choose an environment in which you think the test or pilot could be successful. It's also important to have engaged and supportive unit leadership, and also supportive leadership in nursing administration all the way up to the CNO. Choose a unit that has good teamwork and coordination, and also be sure that when the sepsis screen is taught and the standard work is put into place, that when the nurses pick up the phone, they'll be contacting supportive and responsive providers. I made the mistake and learned that it's not sufficient to simply train nurses on the pathophysiology and the use of the sepsis screen. It's also important to engage and educate those folks who are going to be on the other end of the phone receiving the information with an expectation to act and rapidly implement the items in the sepsis bundle. While you're piloting, it is of paramount importance to get feedback from all staff. As I mentioned earlier, using rapid cycle improvement with the Plan, Do, Study, Act, for instance, to implement a small test of change with maybe one nurse with just 2 patients on one day, to learn from that first test, to iterate, change, or update, and then plan how to improve with the next cycle. When you feel you have something that could be relatively successful, at that point then spread to more nurses and more patients. When you feel that you have a system in place that works on your unit, then consider piling it on 1 or 2 other units until you ultimately reach the spread through your entire med-surg population in your hospital. It's also important to reward engagement and innovation. Remember, we don't want to start with the laggards. We want to start with folks that are interested and passionate about the work. It is also important, though, to include people who may be resistant, to have them in at the outset of the project, to allow them to feel as if they have been given input and that their input is important and valued, and to reward your nurses for doing a good job and highlight their work when you're spreading to other units. I'd like to pass off to Krista then to summarize our presentation.
Thanks, Mary Ann. I think this was very informative from several different aspects, and I think one piece that I think is really important, and hopefully Sean will comment on this as well, is that we really need to partner with our hospitalists and our physicians and our providers on the unit. So this is not a process where the nurses are actually diagnosing patients, but yet working with their providers to recognize patients early. So we do understand that hospitalization for sepsis is common, it's costly, and ward patients have disproportionately high mortality, as Dr. Townsend had alluded to in his presentation. Nurse engagement in sepsis screening programs may be accomplished, but it's necessary that we include our leaders and our staff. And it's important that we establish an understanding as to why sepsis screening is important. We need to put a face to these patients so that the nurses feel a sense of engagement as opposed to buy-in. And we can do this through education and support, and I cannot underestimate the need for support. This is not something that you roll out and expect that this is going to flow on its own. We do need to support the nurses through this process. And we need to also introduce this program on a pilot unit and test small processes, allow staff feedback and modification of the program before spreading to other units. And I want to encourage you that this is possible. We've had success with this, and I wish you all the best in your endeavors to implement this type of program in your institutions. Thank you so much, and we appreciate your time.
So thank you, Dr. Townsend and Marianne and Krista. We have several questions, and we have about 10 minutes left, so I'd like to go ahead and take the opportunity to jump into questions. We have over 2,200 people who've logged into some portion of this webinar, and we have dozens of questions that have come in. Many of the questions are around screening. So the first one is, many of our staff are struggling with screening the patients with regards to, quote, suspected source of infection. Any suggestion for inpatient nurses on how they can identify this rapidly?
So and I'll let Marianne comment as well. One of the things that we actually had this same question when we initiated this collaborative. And basically what we did was we taught a head-to-toe assessment assessing for infection. So we look at wounds, lines, signs and symptoms. We really taught the nurses to think critically when they're doing their physical assessment for the patients. And we didn't want them to have to diagnose. So we can even basically say to them, do you think the patient has a suspicion or an active infection that is being treated? We didn't necessarily require them to say the patient has endocarditis or pneumonia. Basically, if they could come up with the pieces of information that identified a patient as having a potential infection, that was really our potential first goal. And then the nurses actually build on that process. And Marianne, you might have comments on that as well.
Yeah, Krista, I think you're absolutely right. To delve a little bit further, when we educated our nurses, we told them that they should understand that the most likely causes of infection that lead to sepsis are pneumonia, urinary tract infection, wounds or infections of the skin and in the gut. So when we ask nurses, again, as Krista said, not to diagnose these things, but to look at patients admitting diagnosis and combine that with findings of their physical exam to see if there was a likelihood that any of those things may be present. The easy part of this is if a patient is admitted with a diagnosis of infection or is on any type of antibiotics that are not considered prophylactic. But nurses soon became pretty astute at recognizing the fact that, for instance, if a patient came from a skilled nursing facility with an upper respiratory infection, cough, or it had an indwelling Foley, that there was a likelihood, because those two things are so prevalent, that there was a possibility of an infection. Again, I think two things to remember with sepsis screening, particularly on the med-surg unit. Number one, this is a screen and not a diagnosis. We expect to cast a broad net with our screen, and we're not always going to be right. The goal of a screen being sensitive enough is that we will have some false positives so that we don't miss patients. It is then up to the collaboration of the RN and the provider to decide whether the findings of the screen are in fact linked to an infection and whether the patient actually does have sepsis. The second important thing to remember is that the rate of positive screens in the med-surg area should actually be quite low. So often nurses feel a little bit frustrated with the fact that they're doing hundreds of screens maybe in a month and they're only getting one or two positives. I think we should educate the nurses to expect this, but to still understand the importance of the screen when it is positive, and also to communicate the findings of those screens to providers to implement care if required.
So I think your comment segues into our next series of questions. We've had several questions with regards to use of a paper tool. So if you're using a paper screening tool, where would you keep it? How would you communicate those results? And any advice that you guys have on collecting the data and communicating it back in real time?
Yeah, this is Marianne. The paper tools are definitely challenging. But on the other hand, they also facilitate learning and early adoption. So in our, as Krista mentioned earlier when she described the collaborative, she said we basically had three situations with implementing a screen. We had sites that were not yet using an EMR, and so they documented everything on paper, and so that was really their only option. And in those cases, once the screen was accepted as part of the medical record after several tests and iterations, it actually became part of the paper record. We also had two other cohorts. We had two other sections of our collaboratives who had, as Krista mentioned, had implemented an EMR, but because it took basically an act of God to get anything added in a quick manner, they began doing sepsis screens on paper. And to be honest, it was not really ideal. Obviously, those screens could be scanned and put into the EMRs, but for collecting data from those screens, it was manual and very labor intensive. And then we had our third group who had EMR implementation already, and they were able to either access a screen already present in their EMR, or they were able to rapidly add one that the nurses could use. I think Krista touched on one other issue, and that is the use of alerts. And so alerts are really important because the nurses aren't always in the patient's chart, and usually clinical decision support, or CDS, running in the background that looks at new findings such as newly entered vital signs or new lab results, and can alert the provider, either the nurse or the physician, to a change in the patient's condition that may indicate sepsis. Those prompts should really be used to encourage the nurse to perform an actual sepsis screen. Number one, as advanced as our clinical decision support may be, in my opinion, it does not ever substitute for the critical thinking of a well-trained RN. It also allows the nurse to take part in the screening and continually familiarize themselves with the contents of the screen and what the findings mean, and also to have a better understanding of the assessment when they're communicating with their provider. Krista or Dr. Townsend, anything to add?
So I just wanted to add to the beginning part of the question is, what do you do with the tool after the nurse has actually completed it? And I failed to mention that all the units we actually had nurse champions, whether it was an educator or a staff nurse on the different shifts, that would be support, another set of eyes actually on the screening tool. So the one question said, is there real-time feedback? And having that champion would actually allow the nurse who's screening the patient to confirm or accelerate the process up the ladder to the provider in making the determination as to whether or not the patient actually met the screening tool. And then that information was actually collated, and there was someone designated on the unit, whether it was a nurse manager or the nurse educator, to review those forms, look for false positives, false negatives, and learn from that and give feedback to the team. So it wasn't just that the nurses were completing this form and then there was no one looking at it. We actually did look at compliance. So we were looking to see that every nurse was screening every patient every shift. And even if the patient was admitted with a sepsis diagnosis, we still required the nurses to screen that patient every day, every shift, because it's possible that the patient could progress, maybe develop a new organ dysfunction that we could identify early. So this screening tool was used, it was evaluated, and that's why we recommend that you only pilot the program on one unit, because we recognize the work that's involved in getting this program up and off the ground and offering the support that the nurses need to feel confident about the program.
So one last question. We've been talking quite a bit about screening patients on wards, but we're also getting questions about patients presenting in the emergency department. What advice do you have on how triage nurses can quickly assess for infection and overcome any barriers to quickly recognizing and initiating sepsis protocols?
Sean, do you have comments on that?
I do. I think, to a large extent, what's really important, I think, is that we empower nurses to start to use their judgment and have the sense that the patient is becoming infected for some reason or another. And I think to a large extent, nurses actually do know that, and it's only through a lack of willingness to speak their minds in certain cases and or out of fear that they could be wrong that they sometimes don't. There's oftentimes a very clear sense that the patient may be infected, but a reluctance to actually express that. And so working to overcome that by having a positive program that empowers people, I think, is an important feature. The other thing is that some very practical advice, if that's just too difficult to do, is to rely on service criteria to point you in that direction. at screening in an emergency department, for example. At triage, you can check for fever. You can check for an elevated respiratory rate. Those things are easily available to you at that point. Tachycardia is easily assessed at triage. And patients who have those signs of inflammation, if they're positive, can lead you to think, well, wait, I better ask the question, is there an infection here? And then look more carefully at that point. So there are some objective data points, even at triage in an emergency department, where you can say, well, if I've got some positive SIRS criteria, perhaps I have to make a little bit deeper of a dive to see if there's an infection.
So we're at time. I want to thank Dr. Sean Townsend, Marianne Barnes-Daly, and Christa Shore for their time today, as well as the Society for Critical Care Medicine and American Nurses Association for sponsoring this webinar with us. We know that there's several questions that we are not able to answer, and we'll try to answer some of those in follow-up emails. When you close out on the webinar, a post-meeting webpage will appear, which will have detailed instructions about completing the continuing education post-test and evaluation. The access code for accessing the continuing education is WC0922. And with that, thank you for joining our webinar today.